Hello and welcome everyone to today's on-call webinar entitled Creating Engagement-Capable Environments. As mentioned, I'm Carol Fancott and I'm a director at the Canadian Foundation for Healthcare Improvements, and I'm pleased to be your host today. We are happy to be welcoming more than 260 registrants for this session across Canada, and we're pleased to be able to offer simultaneous interpretation for all of our on-call webinars. As I introduce our guest speakers, I ask that you please take a moment to introduce yourselves as well via the chat box. And you will also notice a poll at the bottom of your screen. Please let us know how many people are attending this session from your location. We're fortunate to have an impressive lineup for today's session. First, let me introduce Dr. Ross Baker, professor in the Institute of Health Policy, Management, and Evaluation at the University of Toronto, and director of the MSc program in Quality Improvement and Patient Safety at the Institute. He's part of our expert faculty at CFHI, and he is an internationally recognized expert in quality improvement and patient safety, notably the lead author, together with Dr. Peter Norton, on the Canadian Adverse Events Study. Most recently, Ross has turned his attention to the involvement and engagement of patients and families in quality and safety efforts, conducting case studies in leading organizations in Canada, the U.S., and the U.K., which has led to this concept of engagement-capable environments. Mallory Keller is also joining us, and she's a patient engagement lead with the Saskatchewan Health Quality Council. She began working as a patient and family-centered care specialist in 2010 and became the provincial program manager for the Saskatchewan Transplant System in 2012 before joining the Quality Council. She holds a master's degree of public administration from the University of Regina. We also have Bernie Dopker joining us, and Bernie is the Director of Community Engagement at Five Hills Health Region, and she has been involved on many provincial and regional programs to improve and standardize services across Saskatchewan, and she's also a certified lean leader. Bernie also currently co-chairs the Saskatchewan Patient and Family Guiding Coalition, which includes a group of active patients and family members across Saskatchewan that advises the Health Quality Council of Saskatchewan. And last but not least, I will introduce Rick Farrant, a patient family advisor at the Five Hills Health Region and a member of their Patient and Family Centered Care Steering Committee. Rick has been an active advisor in Saskatchewan since 2012, being involved in numerous quality improvement initiatives, provincial events and conferences, and he's recently been featured in a national risk management journal. Since his first involvement in a 3P design workshop in Moose Jaw in 2012, Rick has been a fervent believer in the value that patients and families can bring to improving patient care and systems of care, and sees this as some of the most important work he has ever done. Welcome to all of you. So in our time today, we will be exploring how patient and family engagement can serve as a catalyst for innovation and improvement. We will learn how engagement-capable environments can support quality improvements at all levels of healthcare, and we will hear from one of our featured case studies about the practice of patient engagement for improvement. First, very briefly, let me tell you a little bit about CFHI. We are a nationally funded not-for-profit organization dedicated to accelerating healthcare improvements, targeting three specific aims: patient and family experience of care, health of populations, and value for money. We focus on building improvement capacity and providing on-the-ground support to spread and scale proven innovations across 7 areas of focus. And we do this by working together with you and offering support that enables patient and family engagement, builds leadership skill and capacity, and applies improvement methodology and coaching through our collaboratives that aim to spread evidence-informed improvements. CFHI has been an early leader in this area of patient and family engagement, and we've supported 51 teams within healthcare organizations across Canada in 4 collaboratives since 2010, recognizing patients as co-creators in healthcare improvement. We also commissioned research by Dr. Baker to help us understand the mechanisms and impacts of patient engagement for quality improvement. Most recently, CFHI was commissioned to do work with Dr. Baker for the Federal Advisory Panel on Healthcare Improvement to explore the potential of patient engagement as a key lever for sustained improvement and transformation of the healthcare system. From this report, we released a book on patient engagement published by Longwoods, and we will direct you to the link to this publication later on in the broadcast. And Ross will be describing a key concept explored in this publication, engagement-capable environments. And now, before I pass it over to Ross, I encourage you to please type in your questions in the chat box throughout the presentations as you think of them. Now, over to you, Ross.
So thanks very much, Carol, and it's a pleasure to be here and to talk about this issue. And I think many people on the phone recognize how critical patient engagement has been in the Canadian healthcare system as it is elsewhere in England, in the United States. And we explored those experiences in some detail in these case studies that are captured in the book. And today I just want to set a context for thinking about this, recognizing that in many settings it's still a challenge to have meaningful patient engagement. And despite the focus of Accreditation Canada, despite the efforts of many leaders to say this is the right thing to do, we see organizations struggling to make this happen. And so today we're going to explore how this can be done successfully with different lenses, the lens of the organizational change and the lens of the policy level change, to think about what patient engagement, true patient engagement, not the checkbox, we have a patient on one of our committees, a sort of engagement that sort of undermines and fails to realize the opportunities that are available here. So I'm going to really frame this issue in terms of a number of different ways of thinking about this. And the first slide borrows, I think, a very useful diagram from Kristen Carman and colleagues in the United States. It was published a few years ago. And Kristen says we need to think about patient engagement at 3 different levels. And of course, historically, we've seen engagement in terms of direct care, in terms of the relationship between patients and the people who care for them. And Kristen says you can think about that as forming a continuum from a consultation mode, which is a fairly low level of engagement, through a fuller involvement mode, and then lastly to a partnership and shared leadership, or we might say co-design mode, where the patient is a full participant in designing care for themselves. And we know from literature on this that if you can fully engage patients, it has an impact not only in terms of the psychology of the patient's commitment to their own health, but in terms of their actual outcomes. And so I think it's very important to see this as sort of a critical building block. How do we create time, create opportunities, and provide the skills to clinicians to fully engage their patients in making decisions about their care, where they want to be engaged or where their caregivers can be engaged? But that's not enough. And today, I think we recognize across Canada and elsewhere that we need to have patients and the experiences and insights that they have be a broader part of the discussions about how do we redesign, how do we improve the way in which care is being delivered in every setting, in hospitals, in the community, at home, so that we understand how to create more effective care that meets the needs of patients and uses our resources wisely within the system. And again, we can see this opportunity to engage patients as things that happen at a consultation level. We ask patients, do they like the changes that we're suggesting, or in an involvement level where they're actively participating at the table, or then lastly in this co-design or leadership and partnership level, where they are true contributors to the decisions that are made, not people who are simply signing off on decisions that professionals have decided are useful ways to improve services. This is a very challenging thing. This was the focus of the work that we did for the Naylor Commission, and that the case studies that are published in this book from Longwoods. And we've looked to see what the critical elements are to make that happen. And lastly, before I move on to some details about that, let's just say that patients need to be engaged at a system level too, at a policy level, in terms of making decisions at a community level about where do we invest money in services through regional health authorities or LHINs, And then how do we make decisions at organizational levels, at boards, and other settings where patients can share their experiences, share their preferences, share their insights to influence that happening. Now, Carmen's typology, if you will, here, I think is very useful, but the thing that she doesn't do is really talk about the connections between these different levels, between patients and their direct care, in the organizational involvement, and in policy making. And I think that's really critical. I think that organizations that have been successful in really moving past token involvement of patients are starting to make the linkage between these different levels moving forward. And so that's a challenge. I think many people still struggle with this, but I think that's the direction we're moving in. How do we make this happen more broadly across the country and in all healthcare environments? And it was in the experiences we had going to England, visiting leading places in the United States, and then working with some of the Canadian organizations that have been successful in doing this, including in Saskatchewan, which we'll hear more about shortly. We've created this idea of engagement-capable environments. And we could say on one level, it's creating an organization where the culture supports the participation of patients at all levels within the organization, and then provides structures and processes that help to support patients in their role as advisors to the organization and to individual patients and staff within the organization. And this is, again, something that will happen at an individual level, at an organizational and a policy level, reflecting the distinctions that Carmen has made. And let me say a little bit more about what I think the key processes are that are important for recognizing these engagement-capable environments. And we have them here as really three critical, interrelated, and interdependent processes. The first one is really the obvious one. It's around enlisting and preparing patients, recruiting people to be patient advisors, recruiting people to serve on committees across organizations, and to participate in quality improvement and governance and policy discussions across the organization. So this means we need effective recruitment, we need effective onboarding, we need ongoing support for patients. We need to think about not only the patients that we have used in the past and are comfortable in working with, but in recruiting people who are perhaps more critical and perhaps atypical in their experiences, and figuring out how to engage them in these discussions moving forward. And that is a challenging set of activities for an organization, but we have to do this on a scale that allows us to ensure that there's a steady flow of patients who are coming into the organization and who are participating to that work and who are familiar with the issues and capable really of contributing in a meaningful way. Now, in order to do that, we have to not only prepare the patients, but we have to engage staff. So the second critical set of processes here is around engaging staff to involve patients. Because, you know, if staff are not prepared to have an equal relationship with patients, then it's not a good discussion at the table, and it can be awkward and unproductive. So organizations need to commit to not only supporting patients, they need to orient staff in doing this. And there's a number of ways in which this can happen. But I think one of the most powerful ways that we saw in several case studies, including the MUHC case study in Montreal, and others as well in Saskatoon, where patients and staff together learn new skills and participate in new projects. So the Lean initiatives across Saskatchewan were an opportunity for patients to learn the skills involved in Kaizen events. The MUHC efforts at transforming care at the bedside were an opportunity for staff and patients to learn together and then to appreciate the differences in perspective, the differences in experiences that those different individuals brought to this. So I think that's a real opportunity to think about ways in which we engage staff. And then the third critical set of processes here are around leadership. The places that are most successful in strong patient engagement have leaders who are role models, who in their daily behaviors involve patients in their discussions and their decisions, and who expect that of others. Remember that staff are looking for leaders to really say, is this a program and set of activities that we really need to become engaged in, or is this something we're doing simply because we need to get through our next accreditation or through the next review that somebody's going to have with us? So leadership is really critical to make this happen, to make patient engagement a core part of strategy and mission in an organization, and where the necessary investments and time spent with patients and with staff are going to translate into activities that really lead to true patient engagement. When you spend time in an organization that is truly committed to patients, it's a different experience than the day-to-day activity we see in many organizations. Patients have a different role. There's a different respect for their view and their experiences. And I think we now need to get closer to that, what that looks like, to understand that in more detail, and to really derive the benefit from others' experiences in making this happen. I'm really pleased that we're going to talk about the work that's been done in Saskatchewan, because I think Saskatchewan has been a leader in this for close to a decade now, with a strong policy focus and strategic investments in patient engagement. I've had the good fortune to be a board member of the Health Quality Council in Saskatchewan, so I've seen a lot of this evolve over time, and I'm pleased to hear more about it on this webinar. So over to you, Mallory.
Hi there, everyone. Thanks for the opportunity to present. So what's happening in Saskatchewan? A whole lot is happening in Saskatchewan, and so I'm just going to walk through a little bit of our history and get into a few examples of how we use policy at the system level to influence patient engagement throughout our entire province. So back in 2009, we had a provincial Patient First report completed. It was commissioned by our government, and the results outlined that we really needed to focus on the patient experience along the full continuum of healthcare services. So, there was pockets of good work, but that it was disjointed. And so that we really wanted to focus on having a health system that was patient and family-centered, and that was our principal aim for the entire province, not for one region, not for one hospital, not for one unit, but for the entire province. In 2010, we hosted the Institute for Patient Family-Centered Care, and I think this ties back to what Ross said, is that we really need our leadership to understand what it means to be patient family-centered. I think a lot of people across the world use this language, but what does it really mean? And getting into the weeds of what does it mean to treat a patient with respect, what does it mean to share information, how do you meaningfully engage with them, and how do you actually collaborate, not only in care decisions at the bedside, but also in provincial care decisions. So each region was then tasked in 2011 to create their own patient family-centered care policies and framework for how they were going to move forward. And what we learned is that that really helped some regions to jump into patient family-centered care and advance their region, but we didn't see the entire province moving ahead. So we had some key leaders like Saskatoon Health Region, Sunrise Health Region, Five Hills Health Region, and others that didn't have the staff resourcing necessarily to focus on this. And so in 2012, our provincial government adopted LEAN methodology as our improvement framework. And at that time, they set a mandate that no LEAN improvement event would go forward without a patient family advisor. And that really set the tone that everybody in the province had to be engaging patients and families. And so there were provincial standards, there were provincial supports in order to have patients and families involved in those events. In 2014, we reorganized ourselves into the Provincial Guiding Coalition. And what this was is a representative, a patient family advisor, a staff lead, and an executive sponsor from each of our 13 regional health authorities and 5 regional health agencies coming together on a quarterly basis, picking a single target for patient family-centered care, and all working towards it. And that was a game changer for us, because all of a sudden we were thinking and acting as one. We were one province, and patients didn't see the regional borders, and they did not deserve to be treated differently depending on where they access care. And so by working together and picking provincial targets, we were able to make some big changes. So I think that Guiding Coalition was really key in helping us to set up the infrastructure to start treating patients and families equitably across our province. So on the screen, you can see a screenshot of our guiding coalition. We report directly to our Council of CEOs and our Deputy Minister of Health. We use working groups to advance our work across the entire province. And, like I said, there's patients and families leading that at that provincial level, not only staff. And I think that's been pivotal to changing the conversation. So our Provincial Guiding Coalition, our mandate is not only to seek to advance the philosophy of patient-family-centered care, but also to support integration of best practices. We've achieved that through our working groups, but I think it's important to note that the logistics of this is not that you need to be meeting face-to-face. This is not cost prohibitive. The Guiding Coalition truly doesn't spend money. We come together on our own staff time, so each region pays their own staff time. We meet via telehealth, and since we eliminated all travel, we've had more participation, and our entire province is engaging versus those of us who are able to afford to be able to be there. In 2015 to 2017, we've had a lot of achievements. We've worked together to create provincial education because education is key. If people don't really understand what patient-family-centered care is, they can't move that forward. We've created a provincial patient and family advisor network, which engages patients and families regardless of where they are via Facebook to connect about their advisor experiences and to sign up for opportunities. We also identified by listening to patients and families who are serving as advisors that they wanted more orientation, they wanted more support, so we created a provincial orientation. All of this infrastructure has helped us to improve our reporting and support, recruitment, handbook, materials, all of those types of things. The other big thing that we were able to achieve is that we have one provincial open family presence policy. Effective March 31st, 2016, all 13 health authorities had adopted the same policy which eliminated all restrictive visiting hours from our province. And that was really based on the feedback of families saying, we don't want to be treated differently regardless of where we access care. And this infrastructure really helped us to achieve that. We also have a provincial policy for how patients and families are thanked for participating. So there's a standard honoraria rate between $70 and $200 that is acceptable, and we cover all expenses as well for the patients and families participating. And it doesn't matter whether they're participating in a quality improvement event at a local unit level or part of our provincial strategic planning. They are provided with a token of our appreciation in way of an honoraria. We've continued to set targets and we'll have more achievements as we come forward. Our current focus is more in supporting the provincial transition to one regional health authority. So in 2016-17, there were over 500 opportunities for patients and families to inform the health region and the health system. By the end of this quarter, I'm sure that number will be closer to 600. And this slide is very hard to see. However, I include it because it does speak to what Ross was speaking to earlier, is that patients and families are embedded in the health regions at the unit level, at the organizational level. They're also involved in our health agencies, so our shared services, our Ministry of Health, our Health Quality Council. And beyond that, they're also now involved in the Saskatchewan Centre for Patient-Oriented Research, where patients and families will actually help to identify research questions and be a part of research teams. So this is an entire network, it's an entire system all working together to really advance patient engagement. I'm going to pass it over to Bernie and Rick now.
Thank you, Mallory, and thank you for the leading up to our examples of what to do and what not to do as we are becoming engagement-capable environments. And as Dr. Baker described in his 3 points of what it means to have an engagement-capable environment, Rick is going to share a story about when we first started and one of the lessons that we learned.
When I was first asked to participate in the 3P process, the designing of our new hospital, I had no idea what I was getting into. And it was also a one-week event. And I thought it was a bunch of patients getting together to discuss the new hospital. I was wrong. When I showed up for the first day, there were only 5 patient representatives. All the rest were executives and nurses. And that's about 50 people. I had no idea what I was doing there. When they started talking about what was going to happen that day, I said to the fellow sitting next to me, I'm out of here at lunch. This is nothing more than a high-class Amway meeting, and they're going to try and sell me something I don't want. I stayed for lunch because they were having a good lunch that day, but I was going to be gone after. Somebody talked me into staying for the afternoon, and we broke up into smaller groups, and they put me in a group with 10 other people, and we started a discussion the first day, and I wasn't in that group more than 5 minutes when the lead asked me what my opinion was, and that totally floored me. Nobody had ever asked for my opinion before. And I said, are you kidding? And they said, no, we want to know what you think as a patient. And that turned me around. The rest of the week went like that. They kept involving me in every aspect of what we were doing that week. I couldn't escape it. They wouldn't let me sit and not say anything. Fortunately for me, I have a big mouth and I don't mind saying what I'm thinking. And they accepted my thoughts. There were no wrong comments. Everything was good.
And that is an example of one of our lessons learned. And in referring back to what Dr. Baker said, we jumped in and we didn't wait until we were ready. But when we were designing our hospital, we knew that we wanted to involve patient and family members, and a group of us had already taken our Lean certification, so we did have some of the skills in order to work together with patients and the rest of the care teams in order to facilitate these events. But we did not prepare our patient and family members properly, and neither did we prepare some of our other staff. And so I think, although we jumped in and we did the best we could, we supported one another, and it did work. As Mallory explained, we soon learned the importance of having an orientation that would ready our patient and family advisors for what they were getting into and whatever they were participating in. And so that is one of the things that our guiding coalition did as a provincial target, was prepare an orientation for all patient and family advisors across the province. We do them by telehealth, so regardless of where we are, we run them every couple of months or every month as needed, and we orientate them together so that they hear what's happening from one end of our province to the other, and so that they understand the importance of what they're doing and what we're asking them to participate in, and how we're asking them to share their experiences in order to enable us to improve things at the direct level, at the system level, and at the policy level. And that leads us to the next thing that we did as well as a guiding coalition is we prepared a staff orientation that we made the framework for and set together all the parameters and information for sharing information with our staff, our direct care staff or our administration staff, in order for them to understand what patient and family-centered care really is and how we can engage and have engagement-capable environments in order to improve things. And as we have done that and journeyed over the last 5 years, we are getting, comments and requests walking down the hallway. We're getting emails. We're getting information sent to us to review things that maybe just small groups of staff are working on. But because we have involved patient and family members to the extent that Mallory has mentioned, with over 500 involvements last year, more people are having contact with that engagement, and so it's becoming to the front of their minds when they're doing something and improving something, to not forget where are we getting our patient engagement and where are we getting their information from. And which led us also then even further down the line into this year, one of our targets was to have a standardized framework for general orientation for new staff coming into our province. And so what a group of us from the Guiding Coalition, along with I think 3 or 4 of our patient and family advisors from the coalition was on that working group. We developed the framework for general orientation and some best practices for the information that we use, the resources we use, and involving patients and families as we go forward with that. And I think that the importance also of using patient and family stories, or patients themselves, to share those stories. And that is something that Rick was very adamant about and has participated here. And Rick, how do you feel that goes when you come in and talk to our new staff?
It's an incredible experience for me to come in and talk to the staff that are being hired and to tell my story. And they're actually interested. They listen. And it opens up a lot of channels for patients and staff, that we're not just sitting back anymore as patients and letting everybody tell us what to do. We have an opinion. And now they know as staff that we actually have an opinion and we count. We're the leaders in our care. And at one time, we weren't. We were told what to do by a number of people. Now we speak up as patients, and we head the team. And it's a nice position to be in. I thought at first when we started this that I would be pushed out, not listened to, but it's been the exact opposite. It's been a very good experience for me as well, that it's opened up my opportunities to get involved in the healthcare in this province and in my community.
And to make a difference in every single person that starts working in our area or in our region right now, and how they think about their patients when they go forward. And I think through this all, and again in that last segment of the engagement capable environment, we've done so well here in our region because we have also had the leadership support in everything that we have done, and every initiative we have taken. And so I think that's really exactly what Dr. Baker has shared with you in his book, or in their book, is that we have to have all 3 of these pillars in order to be truly an engaged environment and continue our work. And as Valerie has shared, the importance of doing it in a large scale so that we are all doing it similarly and having provincial initiatives rather than just a small segment here that are able to advance things. We're all going together and we're working together to improve all those things. And the last thing that I wanted to discuss today was the use of our data. We have been doing patient experiences for many, many years. But now as we went forward in the last year, we have tried to do this with the Guiding Coalition and develop patient experience surveys that we can use as a whole province that are completed at bedside or at desk side if it's an outpatient or client services. But we are doing the patient experience and we're trying to collect data that is put together by a group across the province of the working group in the Guiding Coalition, but we have our patient and family advisors doing those surveys and going to the bedside, asking about people's experience and getting real feedback. And just yesterday, I had a meeting with one of the nurse directors within our hospital in Moose Jaw, and she said, you know what, the information we get back from these surveys, we take it right directly to VisWall every morning or our huddle before and after shift, and it's the comments that we're getting back from these patients that drives our need to improve every day. And I think that is what we wanted to share, and I know that we've gone a little bit over our time, so I will leave it at that and wait for any questions if people have any. Thank you very much.
Thank you.
Thank you. Thank you, Ross, Mallory, Bernie, and Rick, for all of your very insightful comments. And for Ross starting us off and providing us with the framework to be thinking about this work, Mallory, for us to be thinking about it, not just within our own walls of an organization, but in regional and provincial ways of how can we standardize or ensure that this work is happening across boundaries. And to Bernie and Rick, thank you for those sort of practical examples of what it actually looks like on the ground. And I liked your comment, Bernie, about just don't wait. Start, and this is a learning journey for all of us. And so I welcome questions. We now welcome questions. And I see here there is one from Elise, and I will ask that one first. And there's other comments that were posted that I will go back to. Elise asks, how is patient engagement present in primary care beyond the individual level? And I'm wondering if I might be able to move that to Mallory to give us a sense of what's happening in Saskatchewan, and then perhaps Bernie and Rick might be able to comment at Five Hills.
For sure. So in terms of primary care, it can obviously happen in a primary care area. So for example, a Kids First program, Healthy in Home baby programs may actually engage patients and families in their own program design and their own, they may have patient experience surveys, they could have a patient family advisory working group, those type of things. But I think that's happening in Saskatchewan in pockets. It's not necessarily happening strategically everywhere. At the ministry level, we are now working with our ministry branch that is responsible for primary care to say, how are you engaging patients and families at the top? And what is your expectation for primary health care services in the province to say, how will patients and families be involved? One part that our ministry has always been pushing with regards to primary health care is that there is a primary health care patient experience survey, and they're currently revising that survey and doing so with patients and families. So saying, what are the questions that we need to ask you? How frequently do we need to ask you those questions? And what's the best mode? So is it electronic? Is it on your iPhone? What is it? And then how would you want us to use that data? Do you want to be at the table and interpret it with us? Do you want us to take it away and interpret and make changes? What does that look like? And I think that that's kind of a key focus right now in Saskatchewan. Bernie, anything else to add?
You know, I think that actually covers most of it, Mallory. I said we have done a couple of improvement events with our primary healthcare teams and involving patient and families in that. And we have gotten requests for our steering committee, our regional committee on feedback on different programs that they have been working with. But we're just starting to get into that. We're also working on developing or improving the experience survey with them.
Okay, thank you very much, Mallory and Bernie. We have a number of questions that have been coming in. This one is coming from Cindy, and the question is, do you have dedicated engagement staff? So I'm going to start with you, Bernie, for this one to talk about it, I guess, from the regional level, and then maybe, Mallory, you can speak to this at a sort of health quality level and at a provincial level of what kind of staff is required to actually support this work.
I am the only person in our region that is responsible for patient and family-centered care. and I am also the Director of Volunteer Services for the region. Other regions and other organizations have different amount of people with there. I don't think there is a formula set within the province at this time. Mallory, do you have any?
Yeah, so it ranges. In some of our health regions, it's a quality improvement consultant who has a few dedicated hours to supporting patient engagement. In other health regions, in the larger health regions, to be honest, it is a dedicated full-time position. Provincially, we do have a dedicated full-time position as well to support this at Health Quality Council. And I can tell you that you can do it off the side of your plate, but you need to have someone whose job it is, even if it's off the side of their plate. Because there has to be a point person, there has to be someone who's connecting the dots for the patient-family advisors. If everybody's kind of going to one unit or one person that they happen to know in the health region, I think that leads to tokenism and tapping on the same patients and families over and over again, as well as not supporting them with, onboarding, orientation, what have you, because it is off the side of people's plates. Having said that, if you don't have staff, do you wait? No. I would say start and build towards having positions in the future. Start small and grow.
Thank you for that. And I would say it's quite interesting if you think of the landscape over the last number of years, these positions around a leader in patient engagement or patient experience, they seem to be popping up in many of the healthcare organizations nationwide. Another question coming from Mark Bilodeau. Can you share any specific guidelines, selection criteria, selection process for having the right patients engaged in committees? Maybe I'll start with you, Mallory, because you did sort of point to some of the resources that you have, and then back to you, Bernie and Rick, if you would like to add something to this.
Sure. So the core resources that I would send you to are on the Institute for Patient Family Centered Care. They have creating an advisory toolkit, which is a great starting point. The guidelines and selection criteria, I write guidelines and selection criteria for each group that I'm working with, and it takes me a few minutes. Usually it's not an onerous piece. But am I looking for someone with a brand new experience? Am I looking with someone who's been involved as an advisor before? Those type of things. So then I know what I'm looking for. The selection process, a lot of people do interviews. I do support interviews, but it's not a formal interview that I do. It's over a coffee, it's a conversation, it's getting to know the person, because there have been times in Saskatchewan where we've recruited someone and they have a vengeance against the health region and they're coming to kind of advocate very strongly or lobby for a particular cause, and that's not what we're looking for in our advisors. So those interviews I think are really important. And so I would go to the Institute for Patient Family Centered Care. I would also look at the Saskatchewan Health Quality Council website. That is where we have our Patient Family Advisor Handbook. And in that handbook, it's written with patients and families about what they wanted to know before their interview, before they actually came to the table. They needed to understand what they were getting a part of. So that's a resource, and it's open access. As well on there are some of the guidelines that we've created. So open family presence, our policies up there, and all the guidelines of how we implemented that are also available.
I think I would just, I think I would just add to that that I also would use direct staff. I use staff across our whole region, and I say, you know what, we are looking for someone for this committee, for this improvement process or event. And I said, can you think of anyone that comes to mind that has been through care that you feel would be helpful with this? And then I absolutely do the interviews or the coffees, as Mallory has said, with all of our new patient family advisors, because the first thing I tell them is it doesn't matter what kind of experience you have had with us or with any healthcare in the past, but I said what we are looking for is someone who is willing to come not with an axe to grind, but with the heart to help us improve what we do. I think that I talk to every single person about that before we do that. And we have, and it's also very, very important, as Mallory has mentioned in the past, is that you do not use the same patient and family advisor for every single thing, or else pretty soon you have a professional patient and family advisor with only one set of experiences. Do you have anything to add to that, Rick?
I agree with everything you just said. And I was recruited. I was in a couple of different programs in the health region. And the leaders of those programs, we would be in different conversations about things that were going on. And they put my name forward to Bernie. And then I got a phone call from Bernie, would you be interested in what we're going to do? And we really didn't know what we were going to do. But I was recruited through the programs we already have in place.
And your participation.
And my participation in them. And we've just grown from there.
Thanks.
Thank you, Mallory, Bernie, and Rick. I think Ross wants to jump in here as well and also make a comment on this.
Yeah, just to say there's a growing number of resources, and two other places to look are the Canadian Foundation for Healthcare Improvement, which has an enormous set of resources that they've gathered over the last 5 or 6 years with their experiences in running these collaboratives and working with organizations across the country. And then Health Quality Ontario released a series of resources around patient engagement for providers and for patients in the last few months, and so that's something else that's worth looking at.
Thank you. And so I'm looking at the chat box, and there's a number of questions still, and I'm going to focus on 2 of them because I feel like we've had a chance to explore one of the pillars that Ross spoke to in engagement-capable environments. But I want to get to a question that speaks to the providers and one that's actually asking about organizational culture. So I'm going to go back to one around the providers asked by RE, and wondering about what if the providers aren't interested in doing this kind of work? What if they don't care? And have you had providers, how do you get providers to actually care about engaging patients and families in this way? Bernie and Rick, maybe we can start with you and then move it from there. And then I'm also looking at the time because the other one I want to get to is around organizational culture and how do we create this culture. So we'll start with the one about providers. Over to you, Bernie and Rick.
I think that's really quite a hard question to answer just with this is what you do. But I think that when we first started doing improvement work and design work for our new hospital, which is what kick-started our region, I think what we did was we looked for people who were always willing to help and be involved and improve things. And we handpicked some of the providers that started on those first projects and asked them to participate. And it was the success of those events that carried back to the front line and to their co-workers, and ultimately then kind of flushed out another set of people who were interested and willing to try this new process. And I think that's what we've used to build on that for the last 5 years, is that the more people that have been involved with patients and family members in events or reviews or focus groups, the more they have talked to their co-workers and the more providers have come forward and shown interest in it. What do you see, Rick, when you're going throughout?
I find that there are more providers that are actually interested in this process than there are providers who aren't interested. But the ones that aren't interested, after we get involved in a particular program that we're working in, they come around. But there's always going to be a couple of dissenters around that think we're wasting our time. I think my biggest concern is not the providers, but the rest of the patients who can't understand that they actually have a voice. So getting to them is much more difficult than getting to the providers.
Thank you.
Thanks. Mallory, do you want to weigh in?
Yeah, I've had some significant experiences with resistive staff and physicians, and I can tell you that you also can't back down. It's fun and easier to work with the early adopters. But in one unit in particular that I've worked with, I had an initial conversation. The team was very, very resistive, and they are actually now one of the best, most patient family-centered units we have in this entire province. And it took that initial conversation, then we waited about 3 months, let everyone kind of calm down and absorb a bit, come back, and then when that second time when we came back, we created a patient family advisory council, so that was our constant, that patients and families and staff, more and more staff, were going to hear from patients and families and co-design and start developing changes. We also got the medical health lead for that area, the physician, to come on board with us. And there was 13 docs that were assigned to that unit. There were 2. It literally took us having a letter written from a patient to explain to them why it was important for their family to be involved in bedside rounds, to get to the heart of that individual, to change their practice. And we use many, many different strategies. So if you're struggling with that, please connect with me, because I'd love to pass that on, because we have had really good success, and you can't always back down because some of this it's life-changing for patients and families, and so it is necessary work, even though it's hard.
Thank you. Thanks for your wise advice. I'm going to move on to the question from Jane Valentine, and it asks, what approaches were used to create a culture within and across organizations that supports the implementation of a robust patient engagement framework? So really speaking to the organizational level and creating this environment, and maybe we can start off with Ross.
So, I think that's the really critical question, and the challenge with culture is it seems so large and sometimes so elusive and amorphous. We know what a change culture looks like, but how do we get to that change culture? And I think this goes to some of the issues that Mallory, Bernie, and Rick talked about. It's about identifying the particular behaviors that are demonstrative of engagement-capable environments, and then asking leaders to role model those behaviors, identifying clinical and managerial leaders who can talk about their experiences and the positive aspects of this and acknowledge the challenges of doing this. And, the issue of resistance is a real issue. I think we're in a difficult spot in many parts of the country where staff are feeling overwhelmed by their daily work, and they're worried that this is not going to contribute to their ability to go home and have dinner with their family, that this is going to be another way in which work slows down without any demonstrable benefit. And so the critical culture issue here is, can we identify the stories, the experiences, where that engagement of patients actually leads to something that improves care for patients and improves the work environment for staff? And those stories are the critical piece moving forward. If you want people to change, you have to show them that this is a win-win for patients, staff, and the system as a whole. And I think the smart leaders are telling those stories. They're telling the anecdotes. They're encouraging patients to talk about their explicit experiences that they had that made a difference for them. And, we know that people go into healthcare because they want to help people. They want to work with people. They want to make a difference. And if we can connect the patient engagement experiences to those underlying and fundamental motivations that still resonate in the hearts and the minds of staff across the country, despite all the pressures that they're under, I think that's the key. So the work of patient engagement leaders, the work of leaders in total in the health system, is to look for those opportunities, to pick up those stories, to tell those stories, and to reinforce for people the value of doing this. And, we learn from people who resist because we learn about the fears that they have, about how this is not going to work out for them. And we need to take that and listen to those stories and then to really address the underlying issues that make it difficult for people to get on board.
As much as I hate to do this, we need to start wrapping up this webinar. Rick, Bernie, Mallory, and Ross, thank you so much. It's been such a rich and engaging discussion. And as you can see, there are still a number of questions that are left on the chat box, and we will be working with our speakers to see if we can respond to these questions, and we will be getting back to you. So my apologies that we have run out of time. You will see on the screen now that we do have some upcoming webinars, so we do hope that you will join us for some of these. And lastly, what I would like to say is your feedback is invaluable to us for future planning of these webinars, so that we do ask that you take a moment to provide us some feedback on today's session. And you will see that there are 5 boxes up right now. So the first, if you can please respond, the webinar increased my knowledge of how patient and family engagement can serve as a catalyst for innovation and improvement. Secondly, I've learned something new about how engagement-capable environments can support quality improvements. Third, overall, I was satisfied with my webinar experience. Fourth, I will be able to apply what I learned from this webinar in my workplace. And lastly, if you have any other comments or suggestions, we do welcome that. We do welcome them. As Ross had mentioned earlier, I would like to direct you to our CFHI website. First of all, to the Patient Engagement Resource Hub, which has close to 300 resources on it at this time. And as Mallory had commented, also on the Health Quality Saskatchewan website, there are numerous resources as well. So I think you will find some tools that may help you as you move forward in your journeys. I'd also like to recommend you may want to sign up for our CFHI newsletter to hear more about the offerings and news that we have that may be of interest to you and your organization. And so again, I would like to thank Ross, Mallory, Bernie, and Rick for their very engaging discussions, and to Kelly and Sheena back in Ottawa who are working behind the scenes to make all of this happen for us today. And lastly, of course, a big thank you to you, our audience, for joining us today. And this concludes our webinar. Thanks and have a great day.